I'm Jessie Kreiner from Keys for Healthy Kids, and I'd like to welcome you all to episode 10 of Project Echo for Pediatric Obesity. Today's episode is entitled Identifying, Treating, and Preventing Eating Disorders. And with all of that being said, I'm going to turn it over to our host with the most, Mirinda.
Hello, everyone. We're really glad you're here with us, excited about today's topic, and excited to have Dr. Jess Luzier with us. So I'm going to first just introduce her. So she is a board-certified clinical psychologist who specializes in treating children, adolescents, people with eating and feeding disorders, and self-injury behavior. Dr. Luzier is an associate professor in the WVU School of Medicine, Charleston Division, where she serves as clinical director and co-founder of the WVU Disordered Eating Center of Charleston. She conducts clinical research, which has been published in numerous peer-reviewed journals and at national and international professional conferences. She leads the West Virginia Eating Disorder Network to provide outreach to other interested professionals in the state with an interest in best practice treatment of people with eating disorders. She also advocates at the state and national level to improve access to specialized care for people with eating disorders. Thank you for being here today with us, Dr. Luzier.
I am so excited to be with you today. Thank you for welcoming me.
You're welcome. So our objectives today are, by the end of this session, participants will be able to list diagnostic criteria for 2 eating disorders, describe 2 competency areas for interprofessional providers who wish to treat children with eating disorders, and describe 3 prevention techniques for both eating disorders and pediatric obesity. So we're going to start with a poll question first.
At this time, eating disorders affect what percentage of the population? So we're talking prevalence here, 8%, 9%, 10%, or 12%.
So there are an estimated 28.8 million Americans that will have an eating disorder in their lifetime, and that equates to about 9% of the population. So these are people who would meet full criteria for an eating disorder. That's almost 1 in 10 people in the US. So a whole huge swath of our community and our population.
Wow. And I think that statistic that, there's a statistic that's on the slide, says 10,200 deaths per year as a direct result of an eating disorder, equating to 1 death every 52 minutes. That really shocked me. 1 death every 52 minutes of people with eating disorders. So yeah, we have to think about that. I mean, it's a serious, serious thing, which is why we're talking about it today.
Absolutely.
All right, so we're going to do a second poll.
All right, most people who meet criteria for eating disorders live in larger bodies, e.g. BMI above 25. True or false?
Yes, so those 6 of you who said true were correct. Most people who meet criteria for clinical eating disorders do live in larger bodies. As you can see here, eating disorders affect people of all ages. They affect kids. We see kids in our clinic as young as 8 with clinical eating disorders, some of whom were so severe in their presentation that they needed to go into a hospital or into intensive treatment. They affect people of all races and ethnicities, of all genders, although we have a lot less research on the experience of people who were assigned male at birth or people who identify as male. And they affect people of all body habituses and body sizes.
And, you know, I have to say too, I was shocked by that too. Like, I wouldn't have said that. So I was really glad to see that question because, yeah, it's shocking to think about. But, and that's again, why I wanted to have this topic, because it's so important. And so I'm really thankful that Dr. Luzier is here with us. So we're going to start off by having Dr. Luzier define what an eating disorder is. So if you can go into that for us and explain what that is.
Sure. All eating disorders are serious psychiatric and medical illnesses that impact a person's functioning in a variety of ways. But I'd like to go through a couple of the more common eating disorders just so that you have a sense of what diagnostic criterion you want to be screening for and looking for in some of your patients or the people with whom you work. So the first eating disorder that I'll discuss is anorexia nervosa. Anorexia nervosa affects around 1% of the population. It tends to emerge in early or mid adolescence, although it can emerge later in life. Again, we're doing a better job researching that, but it's certainly an under-researched area at this point. And to meet criteria for anorexia nervosa, a person has to restrict the energy that they put into their body. By the way, energy is food. Food fuels your body. Food is required to blink your eyes and beat your heart and breathe your lungs and think your thoughts and move your legs and do all the things that you need to do throughout the day. But when a person does not get enough food relative to what their body requires, this can lead to a significantly low weight. Now, in the olden days, we had really strict criteria about what a significantly low weight was. Now, the clinician has a little more latitude to decide what's a significantly low weight. So you want to consider that this will be a weight that's low in the context of developmental trajectory, age, sex, growth history. So you want to take into account all of those factors when you're making that determination. Okay, so criterion A, significantly low weight. Criterion B, intense fear of gaining weight. And we are talking like terror of gaining weight. It's all the person can think about is how can I live my life and not gain weight? Or even better, how can I lose even more weight? And oftentimes this is accompanied by behavior that interferes with weight gain as well. So sometimes even if a person knows in their head, gosh, I'm really sick and I probably need to fuel my body better and gain some weight, their behavior may interfere. And then criterion C is a disturbance in the way a person experiences their body weight or shape. And this is delusional in nature. This is why when you're treating somebody with anorexia nervosa, you can't talk them out of their deluded body perceptions or body image. It's almost unconscious the way they perceive their body. And it's definitely unhealthy and continues to reinforce those eating disorder behaviors. So that's anorexia nervosa. The second one that I'll briefly introduce to you is bulimia nervosa. For someone to meet criteria for bulimia nervosa, a person has to have first recurrent episodes of binge eating. And a binge eating episode is characterized by two different things. The first is the quantity of food, and the second is the quality of eating that food. So a person has to eat an objectively large amount of food in a discrete period of time, a 2-hour period of time. It has to be definitely larger than what most people would eat during a similar period of time or under similar circumstances. And then in addition to that, that qualitative aspect of a binge is that a person also is experiencing that lack of control during the eating episode, like feeling like you just couldn't stop even if you wanted to. You can't control what or how much you're eating during that binge eating episode. So in addition to the binge eating episodes, to meet criteria for bulimia nervosa, we also need to see recurrent compensatory behaviors. We used to just call these purging behaviors, but we realized as a field, we were leaving out so many other ways to get rid of food that's really unhealthy and unsafe. So compensatory behaviors, of course, we know about self-induced vomiting. That's the most common compensatory behavior that's used by people with bulimia nervosa. About 70% of people with BN are going to engage in self-induced vomiting. But also there's some new ways that have emerged for people to compensate for the food that they eat. Misuse of medications is a really common one. And in fact, I was treating a kid from Southern West Virginia who was ordering prescription thyroid medications on the internet from overseas and self-dosing those medications after binge eating episodes because this kid was so terrified of gaining weight as a result of the binge eating episodes. So that's an example of why we've got to ask these questions and screen for these things accordingly. Fasting is another way to compensate for the food that you've eaten. So I binged last night and I feel so terrible about it. And I'm so scared that it's going to make me gain weight. So today I'm going to have black coffee for breakfast and I'm going to skip lunch. And fasting is one way, again, to compensate for the food that was eaten during a binge episode. Excessive exercise, same thing. I binged last night, so I'm going to watch my smartwatch and watch the calories that I'm burning as I'm running and make sure that I burn all of the food that I ate during that binge eating episode. So these are some of the behaviors that you want to watch for and screen for to diagnose bulimia nervosa. And then just briefly, I'll talk about binge eating disorder as well, because this is a relatively new eating disorder. It's only been around officially for about 10 years now, since the advent of the DSM-5. And to meet criteria for binge eating disorder, a person has to have recurrent episodes of binge eating. You know what that is. It's the quantity of food, which is excessive, and the quality of feeling out of control while you're eating. And then in addition to that, there have to be 3 or more other symptoms that a person meets criteria for. And these include, number 1, eating very rapidly. Number 2, eating until a person is uncomfortably full. Number 3, eating large amounts of food when they're not hungry. Number 4, eating alone because of feeling embarrassed by how much one is eating. And number 5, feeling disgusted with oneself, depressed, or really guilty after that eating episode. So remember, for binge eating disorder, there's no compensatory behavior, whereas for bulimia nervosa, there is compensatory behavior. So that's an important distinction between those 2 diagnoses. But these are 3 of the diagnoses that we see really commonly in the Eating Disorder Treatment Center here in Charleston.
Thank you. That was very thorough. And I hope everybody has a better understanding of what the eating disorders are. So I have a question with that. Is there people with a larger BMI, is there a common out of those 3? Is it more likely to be one of those eating disorders? I don't know if you know this. It's a random question.
It's a great question. It's a great question. You know, when I was first trained in graduate school 15 or 20 years ago, we were taught that most people with bulimia nervosa tended to have a body habitus that was in the normal range, which I'm using quotes there, but the US defines the normal range as a BMI of 20 to 24. Now, what we're finding is that most of our patients with bulimia nervosa would fit more appropriately into the category of overweight, so a BMI of 25 to 29. And then there is a higher incidence of obesity and overweight in our patients who have binge eating disorder as well. So they do co-occur. That said, you can't look at somebody and say, bet they have binge eating disorder because of their size. That would be really unfair. There are plenty of people with binge eating disorder who do not meet criteria for obesity or overweight.
Okay, thank you.
Yeah, good question.
So, I think if it's okay with you, we'll go into the case now. Do you want to go ahead and present the case?
Yeah, and I'll skip forward a little bit here, which I'm happy to do. Oh, shoot, maybe I don't have it up here. Well, I'll describe the case to you. So this is a 10-year-old female who was referred by her consulting psychiatrist, whom she met in the emergency department. She presented to the emergency department because she was suicidal, she was in a diabetic crisis, and she was extremely malnourished. And her presenting symptoms included a 6-month history of extreme weight loss. She had lost about 20 pounds. Her highest weight was 76 pounds and her lowest weight was 56 pounds. And she was 54 inches tall. So she had a very low body mass index. She was dishonest when it came to her food intake. She restricted how much she ate significantly. She would hide, refuse. She would smell her food, but then she wouldn't eat her food. She would chew excessive amounts of sugar-free gum instead of eating. She was counting her calories and her carbohydrates. She would look up information on the internet about how to lose weight, and she would specifically look up information for how can a person with type 1 diabetes lose weight. She had urges to omit her insulin, even though she was mostly prevented from doing this by the grown-ups around her. She engaged in vigorous, compulsive exercise. So she was playing multiple sports, but she was also obsessively walking laps around her house because she wanted to try to get rid of as much food that she had eaten as possible. She was extremely afraid of weight gain. She would only wear big, baggy clothes. and she was very depressed. She had been depressed, her depression emerged a couple of months after some of these eating disorder symptoms emerged. And that's very common, by the way, because when we're really off kilter with food and nourishment, it can affect our ability to, it can affect our mood, I should say. So she was engaging in self-harm behaviors. She was engaging in suicide planning. And she also had a lot of social anxiety and OCD as well. So as I mentioned, for medical history, she had type 1 diabetes and hypothyroidism. She went into DKA at 18 months, had diabetic seizures when she was around age 4 and 5. And she had a number of symptoms that we would watch for that would be concerning related to the eating disorder, including extreme fatigue, lanugo hair. So that's that hair that little babies have, and people who are really malnourished have it on their face and their arms. It's a fine, downy hair. Her growth was significantly stalled. So she was very, very short and wasn't gaining height the way we would have expected her to. She was fainting, and she also had pubertal delay. So her treatment included family-based therapy in the context of an interprofessional team. So I can talk more about this if it interests you all, but family-based therapy is very similar to some of the interventions that the Healthy Kids program rolls out as well. And essentially we ask the parents to provide wraparound guidance for their children when it comes to eating for a short period of time until the kid can get back on track with nourishment and begin to think more clearly again and be more independent with food. So that meant that mom or dad, in this case, were with this kid every single meal and every single snack. Mom and dad decided what the kid needed to eat, when the kid needed to eat, how much the kid needed to eat. They would prepare the food, place the food on the plate, put the plate in front of the kid, and then sit with the kid and monitor her while she ate. And life stops until you eat when you're doing FBT. So these parents were explicitly guided to put all other priorities aside, and when it was feeding time, to feed their child the dose of food that she needed. So food was medicine in this treatment. They were instructed to feed her 6 times a day. So breakfast, morning snack, lunch, afternoon snack, dinner, and evening snack. And we had to get creative about how we could do that and for the kid to still participate in school. And over time, what we saw was she was able to get right back on track with growing. She was able to gain weight back and then to even continue to grow along her growth trajectory so that she was following that growth trajectory that she had been meeting up until the eating disorder emerged. And we, of course, involved many other team members. So there was a psychiatrist on board, her team, who was treating some of the ancillary depression. There was an amazing endocrine team on board for this kiddo who was providing support and guidance and really aligning with the eating disorder treatment team too. So it was a real success, but a really fascinating case because so much of this kid's concern about weight gain was wrapped up in having type 1 diabetes. She truly believed, because I have type 1 diabetes, I'm destined to be fat. I'm destined to gain too much weight. And so I'm going to compensate by going, a complete 180 and eating very, very, very little so that that never happens. So we also later in treatment had to do a lot of work with her to help her resolve some of those unrealistic and inaccurate thoughts about her body habitus down the road as a result of her type 1 diabetes. But it was a really great case, and she did end up getting a whole lot better. She no longer meets criteria for an eating disorder. Hooray.
That's great. That's wonderful. Yeah, that was a very interesting case. So I have a question with that. I would think that the kids would actually fight back with the parents. Like I know with Healthy Kids, that's been an issue, is that, a lot of times the parents end up pounding the kids and the kids get resentful. And so how do you prevent that? And, how do you address that?
Yeah, that's a great question. We use a lot of different motivational interviewing tactics at that point. in these family-based interventions, and we're mostly working with the parents at first. So in FBT, we believe that the kid, at least at the outset of treatment, when they're really, really engaging in a lot of eating disorder behaviors, and they're either being erratically nourished because they're binging all the time, or they're malnourished because they're restricting their food, in those moments, that kid is not equipped to make decisions about their health all by themselves. And so for, again, just a brief period of time until they can get back on track, their parents need to step into that role and help them make those decisions. In the case of kids with anorexia nervosa, we remind parents that more kids die of anorexia nervosa than die of leukemia, that this is a really serious disorder. And if we can't help these kids get back on track with food quickly, and by quickly, I mean within the first couple of years of symptoms onsetting, then they could face a lifetime of terrible medical and psychological sequelae. So we use that to motivate parents to do this very hard thing for a brief period of time. And boy, is it a lift on the families. We get that. But at the same time, you know, I will often use a cancer metaphor with my families. And I'll say, okay, God forbid your child has a cancer and she's required to take medicine 6 times a day. And you have to administer this medicine and she hates the medicine. It has such terrible side effects. She really doesn't want to take the medicine. Would you ever let your kid miss a dose of medicine? And without fail, every single family I've ever treated in the 12 years I've practiced has said, no, she would never miss a dose of medicine. Mm-hmm. And then I'll say, would you ever let her just take a half dose? Because she's really not feeling it today. She's having a terrible day. She's tantruming. She really doesn't want to take this medicine. And without fail, the families will say, no, I never let her take a half dose. She needs to take the full dose of medicine to cure that cancer. It's exactly the same with treating an eating disorder. These kids need the full dose of medicine. In this case, the medicine is food. And again, this goes for kids who are extremely malnourished. It also goes for kids who are living in larger bodies as well. We want to teach those kids, with their parents' help, that with regular eating, they can start to think more clearly and develop more healthy relationships with food, weight, shape, and all of those health behaviors that we're encouraging.
Great, thank you. If anybody has any other questions, please feel free to unmute yourself or put it in the chat. Dr. Menon actually just put in a comment, which said, great case, eating disorders are definitely more common in patients with diabetes. The other issue we sometimes see in these patients is intentionally withholding insulin in order to lose weight, even if they're not restricting food. And honestly, I didn't know that. I mean, that's interesting. I didn't think about it being more common. And the funny thing is, I think, I feel like type 1, a lot of times they're thinner. So that's interesting to me that was her thought, was that she was going to gain weight.
Right.
So yeah, very interesting. And then somebody else said, I often get a referral for binge eating disorders at Healthy Kids. This is Dr. Jeffrey. Recent commercials. After evaluation, there's usually not the guilt or disgust, but constant hunger and overeating and sneaking because they know they will be told no by parents. The parents are most worried by the sneaking and finding wrappers all over the house. Most common final diagnosis is either insulin resistance, metabolic syndrome with overconsumption of grains, carbs compared to other food groups, or genetic variant of the MC4R pathway with intense hyperphagia. I use Eat26 for screening, but not really great for this common presentation that I'm seeing in Healthy Kids. Any other screen you could recommend that can be done at PCP level or that I can use?
Thanks for that example, Dr. Jeffrey. You're absolutely right. And I evaluate kids like that as well. And very often there are medical reasons why they're engaging in compulsive overeating, and they need the help of a team like yours. So I'm so grateful that we have a team here in Charleston that we can refer kids to. I like the Screen for Disordered Eating questionnaire. So this is a 5-item screen that can be used in a primary care office. And the items are, number 1, do you often feel the desire to eat when you're emotionally upset or stressed? Number 2, do you feel that you cannot control what or how much you eat? Number 3, do you sometimes make yourself throw up to control your weight? Number 4, are you preoccupied with a desire to be thinner? And number 5, do you believe yourself to be fat when others say you're too thin? And this is a screen that more appropriately captures people across the weight and size spectrum compared to some of the other eating disorder screens that are out there. If somebody answers yes to 2 or more of these questions, then there needs to be more assessment and screening for disordered eating. And then I include here some sample questions for you to use to ask about the different criteria that I've already outlined in the diagnoses. It's really important that the language that you use isn't biased. So you want these questions to just roll off your tongue. You want to be cool as a cucumber as a provider or as a treating clinician when you're asking these questions.
All right. And before we proceed any further, I hate to interrupt Dr. Luzier because this is fascinating, but we do have to break this into 2 parts for the podcast purpose. So I think this is a pretty good end point for session A, essentially, so that we can get into the actual screening during the second half. And to session B of episode 10 of Project Echo for Pediatric Obesity. Mind that before the conclusion of this session, we'll be putting a survey link in the chat. Please help us out by filling it out. I will also make sure to include links to the articles referenced and the PowerPoint today. And with all of that being said, I'm going to turn it right back over to those experts. So Miranda, Dr. Luzier, take it away.
Thank you, Jessie. So yeah, we're here today talking with Dr. Luzier about eating disorders, and we're gonna start off by discussing, she did a little bit, but we're gonna discuss more about screening, and so how primary care providers can actually screen for eating disorders. So can you go into, I know you went into it a little bit, but maybe just, do you have anything additional about screening and how we can find patients that are positive?
Absolutely. So if you've asked those screening questions and people are popping positive on those screening questions, that's when you need to get a little bit more detailed in your evaluation to better determine if somebody might actually meet criteria for an eating or a feeding disorder. So some of the questions that you need to be asking include about recent weight change. I always ask kids, what has been the highest that you've ever weighed? And what was the lowest that you've weighed since you've been this tall? And then you also want to understand any change in weight. Have you experienced any recent weight loss or weight gain? In what direction? You want to get a better sense of that description. You want to be asking your patients about their current food intake. So I'm usually asking kids about a 24-hour recall. I want to better understand what a typical day looks like for you for eating. Can you tell me what you ate yesterday? You, of course, want to be screening for binge eating. You want to be screening for purging or compensatory behaviors. And we went through a number of purging and compensatory behavior options, but you want to make sure you don't miss any, because this is one of those questions where if you don't ask the right question, you might not get all the information that you need from the kids and the families that you're meeting with.
And what was the name of the 5-question questionnaire?
Sure.
Again, can you say that?
It was the Screen for Disordered Eating Questionnaire, the SDEQ, and it's a 5-item questionnaire. And if somebody says yes to 2 or more, then you want to do more intensive screening and ask them more intensive questions about food or eating.
And can you find that online to print it off? Is that
yes,
accessible? Okay.
It is freely available. Yes.
Perfect.
Yeah, great question. Do you want me to keep going with these questions, or do you feel like, okay, all right. So some other questions to ask your patient is certainly about dietary restriction. We want to know if they're counting anything, macros, sugar grams, fat grams, calories. MyFitnessPal is the bane of my existence. So many of our patients are using MyFitnessPal because they can scan the barcode of the food that they're eating, and it immediately goes into the app, and the app will tell them to restrict in an effort to lose weight. So that always really worries me. You also want to evaluate, are there foods or food groups that this person has cut out entirely? Many times our patients will cut out all carbs or will cut out all meat in an effort to restrict more and more and more what they will eat over time. You want to screen for excessive or compulsive exercise. So compulsive exercise means I have to exercise even if I'm injured, even if it's sleeting outside or there's a polar vortex, I can't miss a workout. And then excessive exercise is, of course, any exercise that's interfering with functioning and that's clearly way too much given the circumstances for that particular kid. And then last, you want to be evaluating body image or any undue evaluation of weight and shape. You want to understand how important weight and shape are when that kid considers their worth as a person and as a human being.
Great. All right. Well, I think, is that good for screening? Can we move on to treatment to discuss some treatment strategies for eating disorders now that we know how to screen?
Totally. Yes. So I went into a little bit of information about treatment when I talked about the case in the first half of the podcast. But I thought what might be most useful for folks on this podcast would be just understanding the 8 treatment principles for mental health professionals, dietitians, medical professionals, when it comes to working with anybody with an eating disorder. And these were defined and written up by a group of clinicians in Australia, but they're just absolutely brilliant. So the first is, as much as possible, intervene early. Given how much these disorders can impact physical, mental, social, occupational health, it's just so important to aim for the earliest intervention possible to prevent that long-term suffering and even disability in some cases. Number 2, as much as possible, coordinate services. So if your patient needs intensive treatment, if they need to be brought into the hospital, for instance, you want to be coordinating their care across those levels of care, between and among treatment providers, between the patient and, of course, the family as well. And, we can't bill for this, but this is the right thing to do for these kids and these families. They really need all of us to be swimming in the same direction and paddling in the same direction and aligned with each other. Number 3, services must be evidence-based. There is a lot of hooey out there when it comes to treating people with eating disorders and psychotherapy treatment in particular. But keep in mind that evidence-based treatment will require behavior change and an explicit focus on behavior from the psychotherapist. So if your therapist is focusing on the depression or focusing on other family issues and not focusing on food and eating with your patient with an eating disorder, that's a problem. That's not evidence-based care. And it's just really important that they onboard to the very best chance of helping this kid by using evidence-based interventions. Number 4, you have to involve significant others, and with kids, you have to involve their family. And I know Dr. Jeffrey would say the same thing from her treatment center as well, but families are really key, and you have to get them to align with the other members of the treatment team and work with them, and they are the key to success in many cases. Number 5, a personalized treatment approach is really necessary, and that can range from domains like treatment intensity. Does this kid need outpatient treatment? Do they need a partial hospitalization program? Do they need to be brought into the hospital because they're so sick? It means that you need to be evaluating and reviewing how treatment is going session by session. And it means that you need to be culturally responsive as well, considering body size, age, sexuality, gender, all of those important factors that we think about when we're working with these families. Number 6, psychoeducation has to be included with every single intervention. And this needs to be both with the kid or the patient, as well as the families and the significant others. particularly given the degree of misinformation that's widely available about quote unquote healthy eating, weight, and the medical impact of disordered eating. Number 7, you need to have a multidisciplinary care team. Oftentimes, I really need to lean into working with a registered dietitian, for instance, definitely medical professionals, and definitely mental health professionals. And number 8, a skilled workforce is necessary. Clinician expertise produces better outcomes. So we have data on this, that if you've done some CEs, some workshops, if you commit yourself to learning as much as possible about how you can do the very best job screening and treating kids with eating disorders, then you will be able to help your patients with feeding and eating disorders. On the other hand, unskilled clinicians can actually do harm. And I see this every day. I see examples of this every day. Well-meaning, well-intentioned, well-respected clinicians who can really step in it because they just might not be aware of the impact of the words that they use with their patients.
Thank you. That was really good. And that's a great segue into our next discussion, which is actually prevention techniques. So how can providers prevent children from getting eating disorders? So do you want to discuss that a little bit?
Sure. Oh yeah, I'd love to. And I'll just give you a couple. So we're going to include attached to the podcast, one of the papers that we'll include is the paper that I co-wrote with Dr. Jeffries about preventing both eating disorders and obesity in kids, because what we realized over time was that in both of our clinics, we were saying the same thing over and over and over to our families. And that was just really amazing to us. And so we wanted to write it up. So we published that paper a couple of years ago, and we'll include it in your ancillary materials. One of the first most important things that you can do to prevent eating disorders and obesity is to encourage health behaviors and explicitly discourage dieting. So we have a lot of longitudinal research now that shows us that when you diet, and that means you restrict what you eat, how much you eat, you eliminate entire food groups, that it's entirely counterproductive. And in fact, we found that the folks who dieted the most were the most likely to develop an eating disorder. And the folks that dieted even moderately were 5 times more likely to develop an eating disorder. The same runs true for developing obesity as well. Those who restrict their food over time often engage in loss of control eating episodes and overeating episodes over time. Now, that's not the only reason that people may develop obesity, but it may contribute. Dieting may contribute to obesity. So again, we're always discouraging dieting. This is really near and dear to me. Just yesterday, I had another psychologist send me a text message, and her physician had told her, you need to diet down to 900 calories a day. And she was just aghast at that recommendation, that this was a trusted, well-respected physician who was telling her that. Another physician told one of our patients last week, well, your BMI is too high to have an eating disorder. You're not at risk. You're okay if you diet. Your BMI is not low enough yet to worry. Again, really, really worrisome. And what a mixed message for that patient to hear as well. Okay, so another prevention strategy, and this one's so hopefully simple, is eat family meals together. Sit down together and eat family meals. And this is especially preventative of eating disorders for girls. But it also encourages those health behaviors that we really want to instill, especially in our young kids, which may contribute to preventing obesity down the road as well. When families eat together, they eat better. They have better nutritional intake. And when you're eating together, parents can watch their kids. They can pick up on new behaviors or food jags or maybe even some problem behaviors much, much earlier in the trajectory. So we want families to sit down at a table for meals and to eat together as often as possible. Without fail, most of the kids that I treat in my eating disorder center will say when they first come in, when I ask where they eat, oh, I eat by myself up in my room. I cook my own meal, excuse me, and I eat my own food by myself up in my room. And that's definitely a red flag. And then the other prevention strategy that I wanted to mention today is to stop all fat talk and to discourage all fat talk. Instead, we want to encourage positive body talk. I even do this with my coworkers in my own department when I overhear this in the break room. But fat talk or weight talk are any comments about dieting, your weight, other people's weight, encouragement of losing weight, or any sort of weight-related teasing. And what we know is that it's totally unhelpful, right? Families can facilitate healthful habits without weight talk. So we want families to model healthful eating, to model body respectful words and language instead.
That's a really good point. I think it's so important. And I think as providers, we have to be aware of that. Like, we really have to be aware of our language and our approach and how we're talking to patients, because it really does influence. And yeah, so I'm really glad you addressed that.
Sure.
All right. Do you have any, so I guess as a wrap up, before we go into questions, is there any other things you feel like providers really need to know with screening or prevention or treatment with eating disorders? Any last minute thoughts?
You know, I'll push pause and just see if folks have questions or things they want to discuss before I stay on my soapbox.
Okay, well, we do have one question. So do you ever see children with food insecurities, meaning they feel they will not have enough food, overeat, and eventually become overweight?
Yes, all the time. And there's a good body of evidence suggesting that people with food insecurity are at greater risk of developing many different eating disorder behaviors, but especially binge eating behaviors. You know, it really makes intuitive sense when you're worried there won't be enough food and then food is presented, then there's that tendency to hoard food, to hide food, to overeat food. And we do see this in clinic relatively commonly, unfortunately. You know, on the same side of that, food insecurity really affects parents too. And so typically if there's a household with food insecurity, the parents will give their food to their kids and eat less of it themselves. And so parents in food insecure households are at much greater risk of developing disordered eating and developing obesity as well, and as a result. So it's definitely an important factor to consider.
Okay. Thank you. Dr. Jeffries.
Somebody has their hand up.
Yeah, I think that might be Dr. Jeffries.
I think it's Dr. Jeffries.
I actually raised my hand. I want you all to be impressed.
I'm proud of you.
Good job.
Okay, so one of the things that I struggle with the most is when I'm seeing a new patient and I'm going through motivational interviewing and I ask them on a scale of 0 to 10, where do you think you are on the healthy kid scale? And then we talk about their healthy behaviors and then maybe behaviors they know they need to work on or want to work on. I often will identify during that especially with females, that they have body dissatisfaction.
Sure.
They can't wear the clothes that their friends do, and that is their number one motivation. I learned from you that we shouldn't use that as their number one motivation.
Right.
But I really struggle with that, because usually with motivational interviewing, you take what they say and you reflect it back to them. And I still struggle with that. I can't wait to have a boy when they say, I want to run faster. And I'm like, okay, great. To run faster, we need to build muscles. And guess what you need to eat to build muscles? Like, I'm not here for them. But those girls that say, I can't wear the clothes that my friends do, I hate my body. And I'm like, oh, I'm like hearing myself talk, because I see you. What would Jess say?
Oh, goodness, that's scary.
I hear you. Tell me my comment. What am I supposed to say? How do I talk them out of that?
Well, you know how politicians, when they're asked questions, they answer the question that they wish you had asked instead of answering the question that was actually asked? I would probably handle it that way. So I would, in my language, I would reframe what they're saying as, you want to really get to a place where you're respecting your body. You want to get to a place where you feel really good about the fuel you're putting into your body, and you feel really confident in your body, right? Now, that doesn't mean that your body is X size, or that your waist is X inches, or that your jeans are X size. And it can still align with the behaviors that you're going to want to push that kid toward. Yeah. And the other thing I would say is, sometimes, I don't know if this happens for you, Dr. Jeffrey, but sometimes kids don't really have any motivation to make changes. And that I see all the time in my clinic. In part because my really malnourished, underweight kids truly cannot think straight. And so in those cases where there's very little motivation, that's where we need to be really leaning into the environment and the family to make the changes. There's something to say about sometimes kids can't make the right choices for themselves, and their parents do need to move in and assist for a period of time until that kid has illustrated that they can independently care for their body. So I wouldn't be afraid to lean into those strategies as well. And I know you do that all the time. That's why I love that you guys take a family approach, and we certainly take a family approach as well. By the way, that's a real departure from, again, even when I first started studying, I had one physician tell me, oh, when a kid has an eating disorder, they need a parentectomy. You just need to take the parents out of the equation altogether. Just say, I'll take care of it from here. You don't need to do anything. And that's the opposite of what we know needs to happen. We need to support and align with those parents so we can help those parents make the changes in the family that need to happen in the service of this kid's health.
Wow, that's good. We're getting more questions, so I'm going to go on. Are there any good books, podcasts, influencers that you recommend? Was one question.
Oh, that's a really good one. And I'm glad. So I'll start with the social media, like the influencers. There are plenty of influencers who have eating disorder behaviors and like regularly post about them. There are plenty who say that they're in recovery and regularly post about that as well. I really worry about any sort of an influencer who's had a history of an eating disorder unless they're a trained clinician at that point, because I think there's a very high likelihood that that will be triggering to the kid who's exposed to that influencer. Instead, I really try to get kids to follow different organizations that have vetted materials that they can access. Things like Project Heal, HEAL, that's an amazing organization, and they've got a presence across all different social media outlets, including TikTok, that talk about different ways that you can engage with health behaviors and stay in recovery or get to recovery if you have disordered eating behavior. And then in terms of books, most of the books that I have are related to family-based therapy. So I love to, when I have the grant funding available, to be able to hand families books when they come in to see me. There is a book by Janet Treasure called Family-Based Caring for a Loved One with an Eating Disorder. It has a dolphin on the front, so we always just call it the dolphin book because the title is a mouthful. but it uses animal metaphors to teach parents motivational interviewing, basically.
Mm-hmm.
So it uses metaphors to teach parents about how they interface with their kids emotionally. Are you a rhinoceros? Are you an ostrich? Or are you a Saint Bernard? You know, and that you want to be a Saint Bernard because you want to gently get your kid out of the avalanche, right? With just enough guidance, but also a lot of support. And same with a couple of other metaphors that they use related to animals and, again, motivational interviewing. So that's a really good one. There are also memoirs of families that have used FBT successfully with their kids that are really profound and meaningful to families that read them. One of them is called Eating with Your Anorexic by Laura Collins. So that's one that I recommend.
Great. So I think we'll close on these last two questions. I'm going to actually read both of them because they're really kind of similar. And I think you can, this is a good closing, a good way to close. But it says the first one is some patients will admit that their ED behavior started after their provider discussed their overweight or obese BMI during a regular visit. What would you recommend providers say during this talk to help prevent the start of eating disorder behaviors? And then the second question was any other particular tips on how to word discussion on addressing weight for overweight or obese individuals who bring up no concerns with their healthy habits. So I think those kind of go together, that like, how do we bring it up and how do we as providers say it in a way that's not going to, you know, lead them to an eating disorder? So
yeah, such a good question. I'm probably going to lean on my friend for this because we were just talking about this before this opened up. Here's what I'll say. Again, most of the kids who come to me are coming to me for specialty care of an eating disorder. And so it's kind of a no-brainer that we're going to go there and talk about this. But I agree that plenty of damage can be done in a well visit or a sick visit. And, you know, my hearts just go out to these clinicians who are encouraged to, after a person meets a certain BMI threshold, you're supposed to check the box saying I provided counseling about this BMI threshold. And yet that can do so much damage to kids. I've already given you a lot of examples of things that kids have told me over the years that have really been detrimental to them. One that I haven't mentioned yet, but that I know I've talked about this with Dr. Jeffrey is a kid came in and I said, you know, do you have a sense of how this disorder emerged or how these behaviors emerge for you? And she said, yeah, I know exactly when they emerged. I went to a well visit with my pediatrician and I asked my pediatrician, what was this thing on my neck? And my pediatrician said, oh, that's a buffalo hump. And that was so hurtful to her and demeaning to her that she went home and started using disordered eating behaviors to try to change her shape and weight. And I'll say the kids who were formerly obese or overweight and who lost weight using eating disorder behaviors, those are the hardest kids to treat. They're the most stuck kids, and they are so terrified of going back to being obese or overweight and experiencing what they experienced when they were in a larger body. So please, 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 let's all work together not to screw this up. And then Dr. Jeffrey, will you jump on and just say the language that you use?
Yeah, so I've gone through many transitions of language, but now I use growth. I use growth and I specifically say your height growth, this is your height growth, this is your weight growth, and this is your BMI growth. Let's look and see how you're growing. So really when you're I'm not a primary care pediatrician anymore, but I've trained a bunch of them, some who are on this call. And I think that one of the things I remember as a mom is Dr. Preble writing down, here's the 6 month, and she wrote down the weight, length, whatever, for me as a mom. So if you start that in infancy and you're continuing to do that at every visit, those parents, now with EHR, it's easy. You just flip the screen around and say, let's look at the growth. Height's following the line, weight's following the line, BMI's normal. So I think that just talking about growth, we're going to see how you're growing. Just make it normal. If you use weight, that's also acceptable. So growth, weight, they did a big study just recently that was released about, and they interviewed both parents and children to find out their preference, and weight still trumps everything. So growth, weight or any word that the child or family uses, again, using motivational interviewing, any word the family or child uses that is appropriate. So if they say fat, you're obviously not going to repeat that. If they say skinny, you're also not going to repeat that. So I just try to normalize it. I'm like you, Dr. Luzier, when they come, they're obviously coming about their weight. But I have so many families that will say, you know, now we haven't talked about this, and I really am afraid about coming because you're going to talk about their weight. I'm like, well, how am I going to take care of them if I don't talk about their weight?
Right.
So, but they're worried that because of their past experience that I'm going to make their child feel bad and what have you, and they're going to cry. And if you do it right, you're going to have them cry for the right reasons, like that you let them know that this is in the environment and their metabolism, and that it's not their or their mother's fault.
Right.
Yeah, I think that's really good.
Those are the reasons.
We're out of time. But
Okay.
yeah, I think, yes, that is really important. And, you know, I think, again, what Dr. Luzier said about focusing on healthy lifestyle, like it's a lifestyle. It's not about focusing on how much weight I lost, because so many people are asking that. Like, I know, you know, when I did primary care, like they always wanted to know, okay, well, what weight do I need to be? How much weight do I need to lose? Where do I need to be? And it's not about that. And I tell them all the time, it's not about that. As you eat healthy, it will come, like everything will work out. But so I think if we can focus on healthier lifestyle, really, you know, that more so than I have to get to this weight or I'm supposed to be this exact place, you know, so that's the advice that I have too about it. But yes, unfortunately,
don't answer the question.
Back, Dr. Luzier.
Don't answer the question, play the politician. I love
That's
that.
right.
I'm going to start using the politician answer.
Yes. We need to channel our inner politicians. Mm-hmm.
But yeah, please fill out the evaluation link so we can get your feedback. And then there are 2 articles. So I'm going to just tell you the names of those, and they will also I'm going to send them via an email along with the PowerPoint, and they'll also be on the podcast, so you'll have access to it. But it's Evidence-Based Strategies to Prevent Eating Disorders and Obesity in Children. That was written by Dr. Luzier and Dr. Jeffrey. And then the second one is it's ANZAED, which stands for Australia and New Zealand Academy for Eating Disorders. It's Eating Disorder Treatment, Principles, and General Clinical Practice and Training Standards. So both of those I will send. And thank you, Dr. Luzier, for being on today. I really appreciate it.
Thank you. This was a blast. I'm so grateful to be here.
Well, great. I'm serious about having you back.
Yeah.
All right, Jessie, take it away.
All right, everybody, I'm going to quickly wrap us up. Once again, make sure you fill out that feedback survey. It's so helpful. Thank you so much to our experts for joining us, and thank you for everybody who joined in on this session. This concludes episode 10 of Project Echo for Pediatric Obesity. Let's go ahead and take us on the outro song.
5, 2, 1, 0.